is Jill Harvey, and today I'm going to present on the iPARIHS framework, or to give it its full name, the Integrated Promoting Action on Research Implementation in Health Services Framework, but I'll use the acronym iPARIHS for short as we go through the session. Before I start, I'd like to acknowledge that I am working and talking to you from the lands of the Ghana people, and I pay my respects to their elders past and present. And I also acknowledge the traditional owners and custodians of the land on which people are joining the webinar. So in terms of the iPARIHS framework, I thought I'd really focus on these four broad areas: a little bit of background to the framework, where it came from, how we developed it. Then I'll talk about what the framework actually looks like and some of the sort of core constructs within the framework, compare it to the other implementation theories and frameworks that are available, and then I'll illustrate its use in practice in a study to improve the care of older people when they're admitted to hospital. So in terms of the origins of iPARIHS, it's quite old now. Although we didn't call it PARIHS or iPARIHS, we first published on the framework in the late 1990s. And that was while myself and colleagues were working at an organisation called the Royal College of Nursing Institute, where we were leading work on quality improvement, practice development, clinical audit, clinical guidelines, and experientially did not feel that the translational pipeline, as it was depicted as a more linear or rational process, reflected the reality of trying to implement evidence-based change in practice. So we proposed, and again, very inductively, we developed what was then called the PARIHS framework, and proposed that to successfully implement evidence into practice, it actually was a function of the complex interplay between the evidence itself, the context in which implementation was taking place, and the way in which the process was facilitated. And that equation at the end is really just reflecting that we saw successful implementation as a function of the relationships between evidence, context, and facilitation. And when we first published the framework and did some work developing, refining and testing it further, we could see that there was a high level of face validity. And as this review and citation analysis showed, over the coming years, there was really widespread uptake and adoption of the framework across a broad range of different clinical settings, different disciplines, and for different uses, but particularly in empirical studies of implementation. At the same time that people were looking at the framework and using it in their practice or in their research, there were also some critiques that came out. So we could see that, as I said, there was a high level of face validity. A lot of people were using it as a sort of heuristic or a memory aid. But some of the critiques suggested things like that it didn't really acknowledge the influence of individuals in implementation, that it tended to focus on the local context of implementation and less so on the wider contextual factors and influences, that we talked about facilitation but didn't really explain what that looked like in reality and how you used facilitation to operationalize the framework. And then a final one was we used the language of successful implementation but didn't really describe how or what that looked like. So in the subsequent years, we were doing work on describing the constructs of evidence, context and facilitation. But then about 10 years ago now, myself and Alison Kitson sort of looked at those critiques of the framework and refined it to what we now describe as the iPARIHS framework, first talked about it in a book and then subsequently in this publication in Implementation Science. And we represented the framework, many similarities from the original one, but I guess some of the key things that we incorporated were the people, which we've called the recipients of implementation, and we actually were more explicit that facilitation was the active ingredient of implementation. So in the iPARIHS framework, we describe successful implementation resulting from the facilitation of the innovation with the recipients in the inner and outer context. And just to illustrate that a little bit further, you know, in terms of the framework, it does have a broader focus on innovation. So that still involves evidence, but we recognise that many changes in practice are driven by quite diverse sources of evidence. So we've used the language of innovation to mean the implementation of something new into practice. It's more explicitly focused on the people, both individually and collectively. And as I said, we've taken a broader view of context, and we actually talk about the local, immediate local context, the organisational context, and the wider outer context, and see facilitation as the active ingredient of implementation. So to summarise that, like many other of the frameworks that maybe are broadly described as determinant frameworks in terms of looking at the characteristics or the factors that influence implementation, iPARIHS focuses on the what, the innovation, the who, the people, the where, the context, but specifically says that facilitation is the overarching strategy that is used to identify and respond to barriers in relation to the what, the who, and the where. And visually, we represent that as a spiral, really, to try and show that it's a dynamic process with different levels of facilitation and facilitators supporting the process, from local facilitators through to more external and expert facilitators who are likely to be working at that wider organisational or external level of context. In terms of when you would maybe think about using iPARIHS, as I said, it really was initially developed as a determinant framework to really understand the barriers and the enablers of implementation. And that's how many people would use it at a planning stage of implementation, to think about, is this setting, is this team, is this unit, is this organisation, how ready are they for implementation? What might be some of the barriers that we should anticipate, and what are the levers that we could draw on to optimise implementation? But it can also be used during implementation to check how things are going and adapt if necessary, and or to structure evaluation, so to use retrospectively and reflect on how well something's gone. When we first developed the framework, we did develop an assessment tool or a facilitation checklist that people could use to do that initial diagnostic assessment of barriers and enablers. And subsequently, we have produced an online version of that, led by Sarah Hunter and Alison Kitson, to develop a tool called MiPARIHS, or Mobilising iPARIHS, which is currently accessed via our Caring Futures Institute website at Flinders University, and can be used online to do the assessment. And you can see this is the type of then printout that you get, that using a -2 to +2 scale, you get a sense of where the barriers are, and it enables you to develop an action plan around what implementation strategies might be the most useful ones to focus on according to the barriers that you've identified. In terms of the other critiques around the framework, and particularly the one around if facilitation is our overarching strategy, how do you actually apply and operationalize that in practice? So a few things that we did when we revised the framework. One was to develop a facilitator's toolkit around some of the more practical steps that a facilitator might go through in supporting implementation, particularly at the project level of implementation. Then we described more around the facilitation knowledge and skills, and I'll try and illustrate that by taking an example, as I said, from a study of older people in hospital. So the facilitator's toolkit, which we've described in more detail in the book, the Facilitation Handbook, is really just a guide. So it's more like a process model of implementation to think about what are the practical activities that a facilitator might need to do when they set up an implementation project. And we've classified those in terms of stages of clarifying and engaging, so identifying stakeholders, really examining the problem that the project is trying to tackle, setting up an implementation team to lead the work. Then doing that baseline assessment, both of the determinants of implementation using the assessment tool or using MiPARIHS, but also what the actual current practice is. So typically a baseline audit, then steps that involve implementation strategies, action plans, and then moving into reviewing, sharing, planning for sustainability. And obviously it's not as neat and tidy as that, but it gives some practical guidance on the key things to think about. And then in terms of facilitation, knowledge, skills, support, we've suggested that in organisation projects that actually you need a network, that where novice or beginner facilitators are supported and mentored by more experienced facilitators, and there can be this continuum of developing facilitation knowledge and skills. And again, we've examined and described that in more detail in the Facilitation Handbook. So to try and illustrate from a practical example, I thought I would focus on this study, which was led by a physician called Alison Mudge in Queensland in Australia. And it was focused on reducing functional and cognitive decline when older people are admitted to hospital. And there's good evidence that that can happen when an older person is brought into an acute hospital environment. And again, building on existing research evidence, the intervention or the programme was called Eat, Walk, Engage. And the aim of the programme was very clearly about when an older person comes into hospital, ensuring that they remain well nourished and hydrated, that they continue to mobilise, and that they're socially engaged. So the programme was developed and piloted in Queensland, and then in terms of its implementation, it explicitly used a facilitator and a facilitation process. So a facilitator, and by that we mean someone who uses an enabling approach. And in this case, the facilitator was working with ward-based multidisciplinary teams to create strategies that would enable the achievement of Eat, Walk, Engage. And each ward may do it slightly differently, but they were all working to the same overall goals of practice and patient care. And in this project, iPARIHS was used throughout. So at a planning stage to assess barriers and enablers and identify the facilitation strategies. And I'll show that in the next couple of slides. It was used to build the facilitation network of novice, experienced and expert facilitators. There was a midpoint check-in to see how implementation was going and whether any changes or adaptations were needed. And then in the formal evaluation project, it was used to guide the process evaluation of the study. So again, just to illustrate that, the barriers assessment was done pre-implementation, mid-implementation and post-implementation, again using that -2 to +2 scale. And this is just a snapshot from the previous slide, so it's a bit easier to see. So in the context domain, some of the things we would look at would be leadership, team communication, what the culture was like, both in terms of being patient or task oriented or responsive to change. And you can see over time, generally things are trending towards the more positive in this example. In terms of the evaluation study, which was called CHERISH, it was a cluster randomized controlled trial in 4 hospitals. Each hospital appointed a new facilitator who was supported by experienced facilitators from within the project team and then by external expert facilitators. And in the paper that looks at the process evaluation of CHERISH, there's a detailed explanation of the strategies that the facilitators used, and we actually mapped them to the ERIC, the expert recommendations on implementing change, which identifies 9 overarching categories of implementation strategies. And in this study, the facilitators used everything except financial incentives. And that really reinforces the idea that facilitation is like the umbrella, but depending on the barriers or the enablers that are identified within an individual project, the role of the facilitator is to think about which are the strategies that best match the barriers that are likely to be encountered or make the most of the enablers that are there. And again, that's explained in a lot more detail in the process evaluation paper. And then in a separate paper, the outcomes paper, we showed that this intervention led to quite a substantial reduction in hospital-acquired delirium in the intervention wards, that it definitely demonstrated improvements in person-centred practice. And we also saw, looking at the longitudinal journey of the facilitators, that as they worked in that facilitation role over an 18-month period, they began to develop increased skills, knowledge and confidence, and transitioned from being fairly new, inexperienced facilitators to working more broadly as experienced facilitators across a number of wards or across an organisational setting. So, and really the mentorship was critical to that, learning by experience, by debriefing and by supervision, both peer supervision, group supervision and supervision from their mentors. So in concluding and trying to sort of summarise some key points about iPARIHS, I think it was definitely developed originally as a determinant framework to highlight the factors that influence implementation. But as we've developed from PARIHS to iPARIHS and focus more on facilitation, I definitely think it can now be used as a determinant, a process and an evaluative framework using that categorization that Per Nielsen developed. I do think that it is relevant when there's an overarching approach of facilitation and facilitators. So in projects where facilitation isn't conceived as part of the implementation, it may well not be the ideal framework to use. In terms of underlying theories, it is very much premised on a philosophy of enabling others to act rather than persuading or directing. And so it draws on a broad range of theories, again, unlike some of the other implementation frameworks, which would be more explicitly psychological, behaviour change, or sociological in their origins. And we're very late to the party, but are just completing the development of a website, an iPARIHS website, which we hope to make available before the end of the year. And that will have more detail around what the framework looks like, what the facilitation process looks like, and the MiPARIHS assessment tool will be available to use as an online version. So I'll stop the presentation there. I just had one final comment to make, which many people may have seen this slide, and you know, I think there are now a lot of implementation theories and frameworks available, and there's a saying that people tend to stick to their own framework, but I think different frameworks have uses for different purposes. And just reinforcing what I said a few minutes ago, iPARIHS fits when there's a facilitation strategy as the overarching implementation strategy. So thank you for taking the time to listen, and I look forward to the feedback.